So in conclusion to Direct-2, T2Candida accurately diagnosed candidemia at the time of positive companion blood cultures. The clinical sensitivity of 89% basically corroborated the analytic sensitivity of 91% from the Direct-1 trial. T2Candida identified patients with recent candidemia who were negative by companion blood cultures, the so-called T2 positive companion blood culture negative results. And what this reflects is the fact that T2Candida will detect inviable, latent, or non-proliferating Candida cells that will be missed by culture. And moreover, T2Candida was significantly more likely to be positive among that group of patients who were already receiving antifungal therapies. And I think the important clinical implication of this is that T2Candida may identify cases of candidemia that would be missed by cultures among patients already receiving preemptive, prophylactic, or empiric antifungal therapy. So if we take Direct-1 and Direct-2 now, I think we have a pretty good sense of how T2Candida is actually going to function in the clinic. So between the two studies, sensitivity is approximately 90%, specificity is approximately 98 to 99%. And the thing about candidemia is we can go in and we can identify well-described cohorts who have well-described prevalence or pretest likelihoods of candidemia. And with the positive and negative, with the sensitivity and specificity, you can now calculate anticipated positive and negative predictive values in various patient populations. And if you go through this exercise, what you'll find is basically any risk group that you might use the test in, the negative predictive value is exceptional. So even if you were taking non-prophylaxed bone marrow transplant recipients who might have a 20% pretest likelihood, the negative predictive value still remains 98%. And moreover, positive predictive values actually increase pretty rapidly once you get out of the very low-risk groups. So you see here, if you take febrile neutropenia prior to empiric antifungal therapy, the literature would suggest about 2% of these patients will have candidemia. Your positive predictive value basically is 50%. So at some point here, the positive predictive value becomes high enough that you should probably be treating patients, even though you don't know definitively that they have disease. So based on positive and negative predictive values like this, it's now feasible to design antifungal treatment and de-escalation strategies in different patient populations that might incorporate this test result. So for example, at the University of Pittsburgh, we've got a couple of these. These are the first two we've put together. In the medical intensive care unit, we're mostly after septic shock, and Candida is going to be about 3 to 5% of these patients. So here, we're primarily exploiting the positive predictive value to get early therapy on board in patients with septic shock, and then in a smaller cohort who've already been on therapy, we're using negative results to de-escalate. Another approach is sort of the more surgical intensive care unit patients, where now your risk factors are different, and you've got various populations who are at varying degrees of risk for candidiasis, patients who've had abdominal surgery, biliary tract manipulations, and you can go through similar exercises in these various populations, and you can come up with either initiation or, more commonly in this population, de-escalation strategies making use of the negative predictive value. So we're accumulating our data, and hopefully we'll be presenting at meetings in the upcoming year. But I think what it shows is that if you're going to optimize the utility at your center, you're going to have to understand your local epidemiology, what type of disease and what patient populations you're studying in, and you're also going to have to understand your microbiology and understand that the 5 species that the test will identify are in fact the most common at your center.